Thank you for the opportunity to present our work. So just a little bit of background. It is well documented that racial and ethnic disparities are present in patients with peripheral artery disease, and specifically Black African American and Latinx Hispanic patients are known to have higher amputation rates, higher rates of above the knee amputations, as well as decreased odds of undergoing revascularization procedures. Some of the potential sources that have been cited in the literature for these disparities include disease severity of limb threat at presentation, socioeconomic status, patient comorbidities, provider implicit biases, and social determinants of health. One of the focuses, or the focus of our project, is looking at disease severity at presentation. We did a retrospective analysis of a nationwide data set called the Vascular Quality Initiative, focusing on peripheral vascular intervention between the years of 2016 and 2021. There's a classification system known as the Wound, Ischemia, and Foot Infection Classification System that we used as an objective marker for disease severity of limb threat at presentation. Inclusion criteria for this study were patients who had Wi-Fi scores reported and race and ethnicity reported. Groups that we analyzed included non-Hispanic white, non-Hispanic Black African American, and Latinx Hispanic patients. We performed a multivariate hierarchical fine gray analysis, controlling for hospital level variation and the competing risk of death. We hypothesized that racial ethnic disparities will persist in major adverse limb events despite controlling for disease severity at presentation using the Wi-Fi stage criteria in patients with chronic limb-threatening ischemia. Our primary endpoint was 1 year MAL rate, or major adverse limb event rates, which was defined as freedom from reintervention or major amputation. Our secondary endpoints were 1 year major amputation, which was defined as above the ankle, and reintervention rates, as well as 1 year survival. Overall, 80,000 patients were identified with chronic limb-threatening ischemia in the data set, and of those, about 60% had Wi-Fi scores reported and were included in our study. Briefly, there's a baseline characteristics table displayed here that shows kind of demographics between patients with MAL and without MAL. And those who did have major adverse limb events were more likely to be younger, female, have Medicare insurance, and have a diagnosis of coronary artery disease, congestive heart failure, diabetes, hypertension, and dialysis. They were also more likely to have a previous amputation and have infrapopliteal disease, and were more likely to be on a preoperative aspirin. And so the biggest result that we looked at was 1 year cumulative incidence of major adverse limb events. And as we can see in the big chart kind of in the center, after controlling for presenting Wi-Fi stage, Latinx Hispanic patients had the highest cumulative incidence of MAL, reaching about 16 to 17%. Black African American patients had nearly 15% cumulative incidence of MAL, and both of those compared to white patients who had about 11% cumulative incidence of MAL, all of which were significant. We then looked at the individual aspects of MAL, which were major amputation and reintervention. And so starting in the bottom left-hand corner, the 1 year cumulative incidence of major amputation was similar between the Latinx Hispanic group as well as the Black African American group. So it's a little difficult to tell because the lines are superimposed, but their cumulative incidences reached about 5% compared to white patients who had about 3% cumulative incidence. We then looked at the reintervention rate, which is the graph right in the middle at the bottom. And Latinx Hispanic patients had the highest cumulative incidence of reintervention, reaching nearly 12%. And Black African American patients had similar cumulative incidence of reintervention compared to white patients, reaching about 8%, with their lines almost superimposed as well at the bottom there. And then finally, we had the cumulative or the 1 year survival of patients. And it might be hard to tell, but Black African American patients were found to have better survival overall compared to the other two groups. So in conclusion, racial and ethnic disparities persisted in major adverse limb events despite presenting Wi-Fi stage. In our study, we attempted to control for disease severity at presentation using the Wi-Fi staging system. We did a kind of weak weak measure of controlling for socioeconomic status by controlling for insurance status, although this is not holistically representative of socioeconomic status. And we also adjusted for comorbidities in our study. The things that we were not able to control for were provider implicit biases and social determinants of health. Future work should focus on addressing these two issues, both provider implicit biases and social determinants of health, to see if these are major contributors to providing equitable care for these two racial and ethnic groups. Thank you for your time, and I'm happy to answer any questions.
Thank you, Dr. Jaramillo. Thank you. No questions so far, but I think we're going to save those for the end. Thank you for your work. This is very interesting. Thank you. Next, I will have Pablo Suarez join us for his presentation. And thank you, Tiffany, for locating his slides.
All right. Thank you all so much for having me here. Just going to wait until we can see the slides. But while that starts, just excited to present our work. Our work is focused on, limited English proficiency and their association with a decrease in utilization of revision surgeries after hip and knee arthroplasty. Do you know if my slides will come up, Dr. Rincon?
They should. I saw them for a second. Tiffany, we're not seeing the slides.
Yeah, my apologies. I am having some trouble, but I found it.
Awesome. Thank you, Tiffany.
My apologies. Here you go.
And so total joint arthroplasties, including knee and hip replacements, are the most common and successful orthopedic procedures performed. When we're talking about success, evidence shows that these procedures are able to improve quality of life, symptom severity, and pain levels for patients with advanced joint arthritis. Orthopedic surgery is not immune to racial and language-based disparities. As we've seen, research shows that patients with LEP have reduced access and worse outcomes for TJA, or total joint arthroplasty. Patients with limited English proficiency have longer and costlier lengths of stay at the hospital and decreased rates of discharge to home, as well as worse long-term functional outcomes after arthroplasty. And this is determined by International Knee Society scores that are lower for LEP, limited English proficient patients. Revision surgery for total joint arthroplasty is the standard of care for common post-operative TJA complications. And although the incidence of these complications tends to be higher for non-white minority patients, as some of our other research has shown, has not been published yet, revision surgery remains underutilized in these groups. We predict that language barriers are an underlying factor for these disparities we see in non-white minority groups. And our study is the first to explore the relationship of limited English proficiency status and the utilization of revision surgery after TJA procedures. And so our methods, this is a retrospective cohort study where we looked at the electronic health records of patients 18 and older who underwent total knee and total hip arthroplasty between the years of 2013 and 2021 at UCSF, a single academic medical center. In our study design, English proficiency status was the primary predictor variable. English proficient was defined as having English as their self-reported primary language, while limited English proficiency was defined as having a self-reported primary language besides English. Primary outcome variables were the proportions of patients that underwent revision surgery within the first, as well as the second year after that initial total hip or total knee arthroplasty. For our statistical analysis, we conducted bivariate analysis comparing the characteristics between limited English proficient patients and English proficient patients, as well as the rates of revision surgeries that were performed during the first and second year. We also adjusted variables through a multivariate regression model, and those variables were selected based on prior literature of factors that may affect the rate of having revision surgeries and complications, including age, patient-reported gender, BMI, anesthesia, American anesthesia, a score of SAA, physical status, smoking status, case urgency, and surgery type. And so let's jump. Sorry that my lights just went off. Sorry about that. So in our results, as you can see in table 1, we're showing the characteristics, and I won't go through all of them, and I just want to point out the main findings. We had about 7,000 THA and TJA procedures, and out of those, 7.2%, around 577 patients, were classified as having limited English proficiency. And out of those patients with limited English proficiency, Spanish and Chinese speakers were predominant. And then on table 2, we're actually seeing the rate of revision surgery. And as we can see in the first year, patients with limited English proficiency have a 1.4 rate of revision surgery compared to patients with English proficiency who have a 3.2%. So we see that disparity there, as well as 2 years after, we see 1.7 as the rate of revision surgery for patients with limited English proficiency, and then 3.9 for patients with English proficiency at the 2-year mark. In addition, our findings show that on table 3, we see the adjusted ratios, and after adjusting for covariates, we were able to see that LEP patients go through revision surgery at a lower rate than patients with English proficiency, both at the first and the second year. And then, so our conclusions for our study so far is that our institution, our study obviously is limited to our institution. LEP is an independent risk factor for decreased utilization of revision surgeries up to two years after primary hip and knee arthroplasty. Patients with LEP may have less frequent pain assessments and symptoms, and this is an area of study that we are currently invested on, and that's why they might be considered for revision surgery less often. Language barriers may affect access to surgical care even after having an initial contact. In this study, we're studying the revision surgery. So even after having access to the initial TGA surgery, patients are still seen to have decreased access to revision surgery if there are complications after. And these findings are consistent with prior research showing disparate access and quality of care, especially surgical care, for populations who have limited English proficiency. And so that is the findings for our work, and we thank you so much for listening.
Thank you, Pablo, very much for your work, and on behalf of LEP communities, appreciate that. Thank you. Justin, I have you next, and while we get your slides, I hope you're getting ready. My pleasure to introduce Justin Solarczyk, who is going to talk about health disparities in orthopedic surgery. Thank you, Justin. I see you, and I see your slides. Thank you, Tiffany. Justin, the floor is yours. Thank you.
Great, thank you. Can you hear me?
Yes, we're able to hear you. Thank you.
Great. So just some background. Previously, race, ethnicity, gender, and socioeconomic status affects access and outcomes after orthopedic surgery. Disparities exist in musculoskeletal care, including ACL reconstruction. Before this study, no prior population-level multi-payer studies of racial, ethnic, and gender disparities in access to ACL reconstruction have been performed. So what we did, our methods, we used the Healthcare Cost and Utilization Project, also called the HCUP database. We used that to determine demographic and insurance types for those undergoing elective ACL reconstruction in 4 states, Maryland, Florida, Iowa, and Wisconsin, between 2016 and 2017. We also used the US Census Bureau for those states during the same time period to obtain demographic and insurance data for the general population. Statistically, our methods, we used 2-sample equality proportion test, chi-square test, and student t-test to analyze associations. What we found was we had about 28,000 patients total in our sample for the HCUP that the census data period was about 35 million. So compared to census data, a high proportion of white patients underwent ACL reconstruction, a similar proportion of Black or African American patients, and a lower proportion of Hispanic, Asian, and Native American patients. The primary payer was more likely to be commercial insurance and less likely to be Medicare or Medicaid. So that's kind of what we already knew. Non-white patients were more likely to be younger, male, less burdened with comorbidities, and less likely to smoke amongst those with commercial or Medicaid insurance. Non-whites with commercial insurance were less likely to have diabetes. And for Medicaid patients, there was an underrepresentation of Black patients and a similar percentage of white patients undergoing ACL reconstruction. So overall, we found lower rates of ACL reconstruction in non-white and publicly insured patients. And this suggests possible narrowing in healthcare disparities, with equal proportions identifying as Black undergoing ACL reconstruction compared to the general population. But we think more data is needed at the numerous points of care between injury, surgery, and recovery to identify and address disparities, such as access to advanced imaging. That's it. Thank you very much.
Thank you so much, Justin. Thank you for that. My next presenter is Celeste Swain, who will be presenting to us about racial and ethnic trends in cesarean delivery on maternal request. Celeste, do I have you?
I'm here. Hello.
Okay, thank you. And we're locating your slides. Thank you.
Great.
Give me just 1 second. Sorry about that. It's on my other screen.
All right. So my study is called Racial and Ethnic Trends in Cesarean Delivery on Maternal Request. So previous studies have shown that non-Hispanic Black birthing people have disproportionately higher C-section rates and higher rates of birth complications, including maternal death. And these previous studies looking at racial disparities in C-section rates have largely excluded a small but important group of patients getting C-sections. So those are the ones getting primary elective C-sections, also known as cesarean delivery on maternal request, or CDMR. The American College of Obstetricians and Gynecologists recommends vaginal delivery in the absence of maternal or fetal indications for C-section. However, despite this recommendation, there's a small but significant proportion of people who choose to undergo CDMR. Possible reasons for that include control over delivery route, avoiding an unplanned C-section, reduction in risk of pelvic floor injury, among other factors. But the racial differences in CDMR rates are not well understood. So for this study, we completed a retrospective cohort study using the Kaiser Northern California database. We looked at all nulliparous term singleton vertex C-sections from 2016 to 2020. And our primary outcome was CDMR rate by maternal race and ethnicity. And we also looked at various secondary outcomes, which I didn't show on the poster as well. But and then we completed different multivariable regression models. So our results are here in the middle. So the two pie charts show the demographic breakdown of our cohort. We had 12,351 patients in the cohort, and the CDMR rate was 4.81%, which is actually within the range of published national rates of 4.6 to 6.1%. And then this table shows the adjusted odds ratios of CDMR by rates of, or by race and ethnicity. And you can see here that white non-Hispanic people undergo CDMR more frequently than the other racial or ethnic groups. And then I didn't show this on the poster, but some of the interesting secondary findings were that patients who are older, so advanced maternal age, obese, had diabetes, utilized assisted reproductive technologies, and had more prenatal visits, those were the patients who also underwent CDMR. So these results are just really striking when contrasted to the increased rates of primary C-section birth overall among Black people, previously well described in the literature. And it really brings forth the racial inequity of maternal care, that not every birthing person has an equal voice or is able to make equal choices about their mode of delivery. Is really to request a C-section without a medical indication. A patient must first feel empowered to bring that up with their provider. They must be informed of this as a delivery option and about the risks and benefits of a C-section. So observed racial and ethnic differences in rates of CDMR may be influenced by institutional power dynamics, communication biases, and a sense of control over the birthing experience. So potential future research could evaluate the role of implicit bias in prenatal C-section counseling. That's it. Thank you.
Thank you, Celeste, so much for that. Excellent. Our last presenter, Tiffany, if you can help us get the slides, is Abubakar Weget, who will speak to us about the impact of social determinants of health on preoperative opioid utilization in patients with lumbar degeneration. So Abubakar, please join us. Thank you.
Yes, thank you for having me. And while the slides are getting up, I think that the incorrect version was uploaded. I don't know if it's possible for me to share my screen with the more correct version. Well, actually, no,
Yeah, sure.
this should be fine too. No,
Are
yeah.
you sure you can? I can just stop share and give you the
Okay,
way
yeah,
to share.
yeah. I'll share my screen now. Okay, how does that look to everyone?
Yeah, it looks
Good.
great. Thank you. Mhm.
Awesome, thank you so much. So yeah, so I'm going to talk about social determinants of health in our spine patients and how that affects their opioid usage. So as we all know, the opioid epidemic has ravaged this country, and surgeons play a unique role in this epidemic and are very much involved. There are several waves in the opioid epidemic, and it continues to rise with a high incidence of injury and death. It has cost our healthcare system, it has cost our patients, and it has cost ourselves. Just between 2015 and 2018, the estimated societal cost of the opioid misuse totaled over $600 billion. So what can we do about it? From an orthopedic lens, we are some of the top prescribers of opioids. We see these patients in clinics and we do surgeries on them. We have many interactions with these patients. Some studies report preoperative use ranging from 20% to as high as 70% in our patient population, indicating this as an important issue. So we need to take a few steps back to see how we can adjust our role in it. Here we have a diagram from the Kaiser Foundation that lists many of the social determinant health factors that impact patients' health and their outcomes. These have all been shown to independently affect healthcare outcomes in a variety of settings. For example, poverty, smoking, age, and education have been linked to opioid use in previous studies. In this study, we looked at lumbar spine patients that have undergone 1 or 2 level lumbar spine surgery for degenerative pathologies in 2019, who had available opioid data for at least 3 months preoperatively and at least 12 months postoperatively, and looked at the social determinants of health factors. We looked at social determinant health factors that are available in EMR listed here, as well as health-related behaviors that are associated with social determinants of health. In our cohort, we were split almost evenly between patients that are opioid naive, meaning that they never use opioids in 3 months preoperatively, and opioid users that use opioids for at least 3 months prior to surgery. And this is not listed on the poster, but those who use opioids had more prior spine surgeries, more diabetes, hypertension, anxiety, or depression. So we looked at a multivariate analysis of our social determinant health factors and found that preoperative opioid use was associated with 3 main factors. Income below the low income limit, which for the Bay Area is around $80,000 for a single household, unemployment, and METS range less than 5, which stands for metabolic equivalence of task and serves as a measure of physical capacity. Low METS or low physical capacity is a value less than 5. We then looked at postoperative use separately, and as you can see, preoperative opioid use was the factor that is most associated with this. And those who use opioids were more likely to use opioids at both 3 months and 1 year postoperatively and at higher dosages. And here we have a Kaplan-Meier curve that shows that postoperatively at 1 year, our opioid users that use opioids preoperatively were more likely to continue using opioids, 72% of them, compared to the opioid naive group where only 15% continue use at 1 year. So in conclusion, opioids do have a limited role in the management of acute and chronic back pain, but we need to be careful about this. Unemployment and low income were important predictors of preoperative opioid use, along with low METS less than 5. And preoperative opioid use was most strongly correlated with postoperative opioid use. So developing policies and reducing preoperative opioid use would be a crucial step moving forward. And thank you everyone for your time.
Thank you so much for that. That was a wonderful presentation. Thank you for illuminating on that topic, which is, I know, is a key topic going on right now. So we're gonna open up. I don't see any questions on the chat, and I know we have a small group. But I want to repost a question that Dr. Fernandez and others have posed to the presenters, which is, in 5 years, how do you foresee that your work will have advanced health equity and or social justice? So I would love to hear from all of you, but in any particular, no particular order, which whomever wants to go first, but we'd like to keep that theme of advancing your research in the next 5 years.
Yeah, I guess I could give a short answer on my end. So what we really hope is to really make kind of like the policies that we have for post-operative care for our patients to be more personalized. So for example, with spine surgeries, they kind of just give a very, like most patients will get opioids after surgery, even if it's not too invasive, they may still be giving opioids even if it may not be necessarily indicated. And for some patients, just depending on their settings and where they are, opioids can be kind of like a good stopgap for pain, but you still need rehab, you still need all these other things. So then if you know more about the patient and more of this information is provided to the physician during the visits, they can make a more personalized plan for how to control patient's pain post-operatively rather than trying to get every patient on the same trajectory where some patients may not have the means to do so.
Got it. I appreciate that that note on more personalized approach. Thank you. And less automation, I guess, of what's prescribed for them. Thank you. Did I have anyone else? Celeste, or, Dr. Jaramillo, Pablo, Justin?
Yeah, I can go.
Cameras on. Thank you, Celeste.
I think what this research is going to change for me is, instead of waiting for patients to come to me requesting a primary elective C-section, just maybe present it to every patient, and maybe this is something that everyone can do eventually, present it as a possibility, but not the recommendation, and go through the risks and counseling so that we're not just leading to this bias where only patients who maybe have heard about this as an option will reach out to us. So just making it more equitable for every patient.
And it sounds like more education is needed so that more people know that this is an option. Thank you. And I welcome the presenters to keep your cameras on. Pablo, did you want to add something? All right. I mean, I would love to hear your answer to that question. Thank you.
Yes, of course. I think just coming from like an immigrant background and being LEP myself, like I think that or having experienced LEP in this country, it's just another implicit bias from providers that we often don't talk about, especially in surgical fields. And so my hope is that our work and the work of others will continue this conversation and will continue to enlighten disparities that often are collinear with racial and ethnic disparities. And so hoping to just elucidate more on that topic.
Thank you. Yeah, absolutely. More access for LEP population. So thank you. More education, personalized information. Thank you. Those are great insights. Dr. Jaramillo, did you want to add anything? Thank you.
Yeah, thank you. I at least for our project, I feel like we wanted to see if disease severity at presentation was an actual reason for why these disparities exist, between the different races and ethnicities. And so now that that's not the case, I think the things that we need to focus on are the implicit biases and social determinants of health as the next steps in figuring out if they do and how to address those issues. And so one of the next projects that we're starting up is looking at food insecurity in patients with peripheral artery disease and seeing if they have adequate access to foods, because if they're not, if they don't have access to healthy foods, their diets may be more focused on carbs and processed foods, higher rates of diabetes and poor wound healing, et cetera, et cetera. And so trying to focus to see on how well they have access to these foods and then ways that we can connect them to resources is our next step in our project. And I think that's kind of where the direction of where we should be headed towards, is looking at these social determinants of health and how to address these issues specifically for these patients' populations.
Yeah, that's a great point on all the other factors that impact access. Thank you, and healthcare. And I have a note on the quote from on the chat. I'm sorry, from Eric Smith. Eric, would you like to unmute and just share your thoughts?
Oh yeah, totally. Yeah, Abu, like it's like that this work. I do work in social determinants of health, and I'm like really inspired that a lot of people are doing this, and it's encouraging. I think one of the challenges, at least what I've seen in this using the Epic function for this, is that people like there was a whole departmental meeting in surgery, and some people didn't even want to complete it because they were like, well, what do I do with this information? So I'm just curious that is this a departmental difference? Like, did you guys have a lot more buy-in in your department for people using this? Or maybe there was a lot of missing data in this regard. So I guess it's just like more of a narrative like question, like how did you deal with that and how are you thinking about that in your data?
Yeah, so there definitely is a lot of information missing. So like, for example, for our study, we could even assess education as a factor, which as many people would expect, that's a very important social determinant of health factor to really think about in these projects. So there is a lot of information missing. I don't think it's specifically, that like our department is collecting more information than other departments. I think it's like just like a lot of chart digging per se, and just trying to find like specific notes that noted these factors for our patients. In regards to getting buy-in, I think the most important thing is going to be research that we're doing right now, right? Just first we're kind of like showing how these factors influence the outcomes of our patients, and then next step is to show when we intervene on some of these factors that are modifiable, that it does improve healthcare, it does make it more efficient and better quality for the patient. So that's kind of like one of the next steps that we're trying to do on our side, is to kind of create like a policy-based approach and then prove the efficacy of looking at this data as something helpful, which will then hopefully get more buy-in to collect even the more other important data like education, for example.
Thank you. I see another comment on the chat. Abu Bakar, do you want to, you just made your comment. Did you want to add anything? That was Eric. Okay, I got it. Sorry.
And also one thing I'll also add,
Thank you.
like so some of the factors that we looked at, they are tricky to find in Epic. So then if these are things that you're interested in looking at, I'm more than happy to show you how to find some of this information in Epic if you ever want to chat about it.
Yeah, so thank you. I appreciate you guys mentioning Epic, because it's certainly we hear this within the Office of Diversity a bit of offline about how some of our systems are yet not designed or even aligned with the realities of the populations that we serve, and to capture all these things that we know, all the research that you're doing, what we've heard on this past couple of days, it doesn't even capture and it doesn't provide the space to capture that information. So thank you for mentioning that. I'm gonna leave a few minutes for other questions or comments. I don't see any on the chat. I know we went quickly through some of the presentations, but I want to see if there's any other comments or questions. And Tiffany, I know we have a survey, correct, that we're hoping people to complete?
Yes, I'm going to put the link in chat so that you have it, and as well as just project it here so that in case you're on your phone, you can get to it right away. But as you may have seen from the last main session, that we have an exit survey. So please take your time to fill this out, and really appreciate your feedback and how you feel about the session, so that we can make it better even for next year or the future sessions that we host.
Thank you, Tiffany. And as you heard, this is our 15th year doing this, so just any feedback that we can get, it definitely helps to get a better program and hopefully to get more participants. It's been 2 wonderful days. I don't want to hold anyone. I know you guys have done a lot of work to get us here. Thank you so much to all of our presenters. and our participants for joining us this morning. We appreciate your contributions to our research and our practice on healthcare disparities. Please complete the survey and be sure to follow Office of Diversity and Outreach. We have a number of events this month for Disability Month and Diversity Month, and we hope you can join us as well. Thank you, everyone. Have a happy Friday and have a good week. Thank you.
Thank you, everyone.
Take care.